The William Tell Overture, the reason I play that is because my guest is likes to play the guitar. So I thought I would put a guitar song on there. Glenn Campbell, William Tell Overture. Can you do that, by the way?
Never tried that one.
You never tried that one?
No.
That one's one that you have to put your fingers in therapy when you get through because. But the guy was absolutely an incredible guitarist, Glenn Campbell from William Tell Overture. Good to have you, sir. Appreciate it very much. Children's Medical Group. A little about you, that you are a native Mississippian?
Yes, sir. I grew up in Prentiss, Mississippi, down in Jeff Davis County.
Yeah. I love the reason that you got into children's practice. I thought that was pretty good. If you want to kind of explain that to the audience here.
Yeah, so I did not plan to be a pediatrician when I went to medical school. I thought I was going to be a brain surgeon, and realized that was incredibly too depressing. And so the reason I chose kids over adults, besides the fact I just had always enjoyed working with kids, had always been the camp counselor, all those things, was that three things. Kids get well, they don't cause their illness, and they only have one thing at a time, where, in general, adults are kind of the opposite of all of those. So.
All right, we want to talk about this. This is a couple of bills here, and both of them mirror each other, 2140 in the Senate and 775 in the House. They're the Mississippi Prior Authorization Reform Act, and so we can make this simple and entertaining because it is important for the people. To give me a little bit of a synopsis and bullet points on what we're talking about.
Yeah, so let me give you a little background first on how we approach this. So in August of 2022, so not that long ago, we decided to form a group called the Mississippi Independent Physicians Practice Association, or short is MIPA. Because we felt like we really didn't have a voice for the private physicians in Mississippi, which are most of your family docs you go see, pediatricians, internal medicine docs, and a lot of specialists, too, are still private. And not that we didn't feel like a lot of our things were out there, but we felt like we really needed a better voice to kind of speak for our patients and to make sure our patients were put first. And try to cut through some bureaucratic red tape and insurance difficulties. So when this group was formed, we sat down and brainstormed and looked at what was going on in the rest of the country and felt like the biggest issue was the difficulty with getting medical services, medicines, procedures approved due to the prior authorization issues. A lot of these issues were taking people weeks to get approved for necessary surgeries, medicines they needed, those kind of things. So we felt like it was time to kind of streamline the process, make it much more transparent, and make the time frames reasonable for when we would get these approvals. So we approached this at that time. This is our third time to have a bill up. Basically, the main points of the two bills, like you said, Senate 2140 and House Bill 775, are to, one, make the process transparent, to make sure that the insurance companies have to publish the items that require prior authorization, that the steps to get prior authorization are transparent and apparent, that you know that what needs to be done. We also wanted to make sure that these timeframes, like I said, were reasonable. Mm-hmm. So in these bills, we're asking that non-urgent medical situations be approved within 5 calendar days and urgent situations within 24 hours, and then medication approvals within 2 days.
Okay. Are those times basically set now, but they're not adhered to, or they're flexible?
There are some time sets, but some of the way it's written now, some of these things can take. They're allowed up to 30 days for some of these things to be approved, which you can imagine with
even on urgent.
Well, urgent's trickier. The time frame is longer right now, and there is some waffle in it, which we feel shouldn't be there. We feel like for patients to be able to get what they need, especially in an urgent situation, needs to be within 24 hours.
Are there consequences to the insurance company?
In the bill, yes. There are fines defined that can be up to $10,000 for directly violating the parts of the bill.
Per violation.
Per violation, correct.
Is it something that some members of the House and Senate may worry that the insurance company might decide not to write it or just not to do business in the state?
We haven't really seen that concern. Like I said, due to the fact that we've dealt with this bill 3 times now, we've had really strong support both in the House and the Senate. Senator Michelle, as the head of the Insurance Commission in the Senate, has been incredibly supportive, and his committee has. Matter of fact, the bill's already come out of committee and also passed the Senate 52-0, and had immediate release to the House.
Dr. Stephen Chevalier, who's at the Children's Medical Group, have you seen this in the past? I wouldn't want you to give names, of course, but just an example of how this happens. You have someone who it aggravates the heck out of you. You can't get an answer one way or the other, and I guess it happens a lot.
Yeah, it happens, unfortunately, literally every single day. The American Medical Association has done several studies over the last couple of years looking at office time, resources that are used in this. And currently, the stats are that the average physician per practice has 45 prior authorizations per week that go through, and that the amount of time this takes with staff and nursing and all to approve just each week is 14 hours of business time.
Yeah. What it seems like, I'm just digging around here, but it seems like what you're asking for is mostly just update as far as technology is concerned. So, like for instance, the transparency. How do you get that information out? Just with a phone call?
Well, right now we really can't necessarily get the information.
You don't even have it.
Right. We can call and ask, well, does this, what are the list of things? And, it's not provided to us. So to me, it's fairly common sense that you should be able to have a list of things that require prior authorizations.
They've got the list.
Yeah,
of
course they do. Yeah. So all we're asking is that we're able to see this information, that we're able to, that it's evidence-based medicine used to deny claims and to approve claims. A big part of this bill is that we want the people who understand what the procedure is to be the people who make the decision. Right now, a lot of times, Paul, when you're dealing with these things and you have to talk to someone on the phone, you're getting someone that's not even a practitioner. You're getting some clerical person. You're getting a nurse practitioner. When you're talking about a complex surgery or those things. So in the bill, we do ask that the physician be at least knowledgeable of the procedure, which usually means they practice within that specialty. Yeah. They do have to be board certified.
So the insurance company still has the right to refuse, but they just got to refuse faster.
Yeah, they have the right to refuse. They have to refuse faster, and they have to actually use some evidence-based medicine to own that refusal. We do have an appeal process built into this, and there are timelines, and we're also asking the same thing from the physicians in that they be board certified, that they be specialty specific, so that when these things are done, it makes sense.
Yeah, you've been doing this. You said 3 years. Working on this?
Yes, sir. We had a bill. It was pretty quick the first time. It was getting our feet wet because we didn't start until the fall. Last year, our bill went through the Senate 49-0, and through the House, I believe it was 103-5. So we had overwhelming support in the House and the Senate at that point.
And then what happened?
Well, then unfortunately it was vetoed by the governor.
By the governor. Did he give a reason for that?
He did. We got a detailed account of what their concerns were.
And they were?
Well, some of it was they wanted more time for their approvals. So the non-urgent, we tried to address a lot of these individually. We've met with the governor's office. Met with his representatives and sat down and redrawn some of this. So,
you feel like you've solved those problems?
I feel like we've addressed the ones that made sense to address. Yeah. We extended the non-urgent time from 2 days to 5 days. He wanted it to be under the purview of the Department of Insurance instead of the State Department of Health, which we made that change.
Okay. You made that change. Okay,
yes, sir.
I got a couple of things. Can you hang on for a second?
Yes, sir.
couple of things on the transparency that I'd like to ask you. And again, it's Dr. Stephen Chevalier. Is that pronounced in four different ways, or is that it? That's it right there, Chevalier?
Yeah, Chevalier is the preferable one, yeah.
I love it. Children's Medical Group. Back with more coming up. Spending some time together, learning about things that matter to us, and live from the Trustmark Studios. Don't stop investing in your future. Save for education or plan for an early retirement for Generations. Trustmark has helped people live their dreams. Let them help you. Trustmark, people you trust, advice that works. Wealth Management, a division of Trustmark. The bill, this is one of the bills to require health insurance, take two here, to require health insurance insurers to do the following: maintain a complete list of services for which prior authorizations are required, make any current prior authorizations, requirements, and restrictions readily accessible and posted on its website, to prohibit health insurance insurers from denying a claim for failure to obtain prior authorization, and to require health insurers to make certain prior authorization statistics available on their website. That's just some of it. In the transparency part, since you've been working on this for 3 years, there's really nothing proprietary that they don't want to release, is it? I mean, it's common knowledge as far as most of the information that's out there.
Yeah, I mean, in our opinion, it shouldn't be proprietary if it is. You know, I mean, these are just stats that kind of guide our ability to get our patients taken care of better, to get these prior authorizations approved quicker, to get the proper therapy for patients, procedures, medicines, et cetera. So,
have you gone over the bill, or anybody from your organization been in contact with the executive branch to say, okay, have we mounted all of your objections and met all of those, and anything else that we should do?
Yeah, like I said earlier, we have met with them. We have looked at things. Like I said, we changed timelines. We've changed who the governance is under. We decreased the fines for breaking the bill or law at that time significantly. We've addressed a lot of the issues we could to try to make this fair and reasonable and acceptable to all those involved. You know, and there's lots of talk about, you know, obviously cost is always an issue. Insurance Commissioner Cheney has come out and said that his studies have shown there wouldn't be any significant cost to the increase to the state plan or to Medicaid if this is passed. And that was another provision. Those were added to the new bill based on the governor's office desire that they be included. And, of course, us as physicians want this to be included for everyone. On the flip side, when you're talking about costs, there's lots of proof that there are lots of costs built up by prior authorizations themselves. Physicians have been able to show in the large AMA study that 2/3 of the time that patients require step therapy, that the initial therapy, which does cost money, is not sufficient, and so they're needed to be treated a second time. We see that almost 2/3 of the time it requires extra visits. Patients have to come in again because the original things the insurance required, and before they would approve the thing the physician asked for was ineffective, and that half the time it results in emergency room visits, which we know are extremely expensive. And they've also in these studies been able to show that 60% of the time it increases the amount of time that the worker or person is out of school or out of their job, which of course is very expensive for the society.
Most of these changes, Doc, in the urgent care, in emergency care, or not in the emergency care, because those are already kind of set, aren't they?
Yeah. If it's a true emergency, then the insurance can't deny you a trip to the emergency room, so that's already covered. What we would like, though, is when it's not an emergency, because people feel like they can't get the care they want because they can't get the prior authorization approved, is for them in that situation to be with their regular doctor, which is much more efficient cost-wise and patient care-wise than flooding the emergency rooms. So, that's a big part of it, is just trying to get the proper care for patients in the proper time frame.
Okay. And before we leave you, what's the status again? You said they're out of committee, and what's
Yeah, so in the Senate, the bill passed unanimously, and it was immediate release, so it's already been released over to the House. The House Bill 775 has already come out of committee with no opposition and is on the calendar in the House.
Does it mirror the Senate bill, or are there some things in it that you worry about?
No, we're happy with both bills. There are things in each that we would like to move forward. Of course, there's nothing really any negative concerns on us with those bills.
Yeah.
I would like to thank both Senator Michelle and Representative Creekmore for pushing these bills through the committees and getting them out quickly. So that we have time to address any issues and hopefully be able to get these bills passed.
If it does pass and is signed by the governor, it becomes effective July the 1st?
Yes. Now there are things in here since these require electronic abilities that take time. The insurers have until January 1 of 2025 to have everything in line, and the clinics and physicians have until January 1 of 2027.
I think they probably could do it within 2 days, but you give it up to January of next year.
Yeah, I mean, the technology's definitely there already.
Sure it is.
It's just, we're trying to give enough room that's not part of the pushback.
You just look at this, though, and you wonder what the cost is going to be to them. It doesn't seem like, as far as the technology is concerned, it can't be that much. We're talking about the insurance companies here.
Yeah, I mean, in our view, we don't feel like this will be any kind of significant increase in cost. Mm-hmm. And we feel like in the long run, it'll be a decrease, like I said, because you won't have to utilize things that are unnecessary. You won't have to go through step therapies and additional visits and ER visits. And
it's going to be better for them.
Yeah, much better for, I think, everybody.
Is it done in other states? Are we just lagging behind on this one, or do they do that everywhere?
Well, we were fairly early to the charge when we brought this up 2.5 years ago. At that point, only Texas had legislation. But in the time that we've tried to get this bill through last year, 12 other states have enacted legislation. There's a big move federally towards this. The AMA is pushing a large bill there. It basically almost every state's looking at something right now because it's such a problem. We just, and like I said, the point is to get patients cared for. And that's the whole purpose of why we formed this group and why we've written this bill and tried to move it forward.
I think the general public and the large portion of the House and Senate who listen to this program are better informed, and we thank you for coming in. Don't charge me extra for this visit. Let me throw something else on you here. As far as children's medicine, and we're not talking about young kids. Well, I shouldn't say that. Young kids, older. Because one of my other stories here is a new study on marijuana, medical marijuana, or marijuana, and the increase in accidents out there. Accidents as far as poison control, where it is legitimately in the house as far as medical marijuana, and accidents in teenagers who are driving under the influence. You see any of that escalating in the state?
I mean, that's always a concern when anything like, a previously illegal substance is made legal. In the pediatric world, I really so far have not seen an increase in that.
Good.
It's very tightly controlled. It tends to be really only cancer patients in pediatrics. So we haven't really experienced that yet.
How about the gas station heroin and things such as that in older kids?
Well, we've definitely had instances of, vaping causing lung disease and more serious things along those lines. And so we try to counsel all of our teenage patients, especially about the dangers of that.
Has that increased over the last few years?
I would say somewhat. Somewhat. It kind of has replaced smoking. It was more like traditional cigarettes is what I had to talk to them about, and now it's more vaping and those things.
I appreciate you taking time to come in, sir.
Great. Thank you.
You got it, Dr. Stephen Chevalier. Chevalier?
Anything close.
We were pronouncing that today about 4 or 5 different ways, and I said it's a beautiful French name, and it is French, is it not?
Yes, sir. Yes, sir.
I will, thank you, sir. Appreciate it very much. I will introduce to you Dr. Daniel